Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to the Sensei podcast. It is a great pleasure to introduce our guest today, Dr. Alexandru Achim from the Cluj Heart Institute in Transylvania, Romania. Alexandru, thanks again so much for being with us today. Looking forward to talking to you about your journey in interventional cardiology and becoming an expert CTO operator.
Hi, Manos. Thank you for inviting me. It's really an honor. When I received the email from you, I was the first minutes I was really shocked, and then I was really humble. Because I'm really young. I'm not. That your podcast is called Sensei, and that somehow implies that you should have a wide beard. I don't have a wide beard, but I'm really young. But I've traveled quite a bit, and I've seen quite a bit. So I will try my best, to share what I've learned with your audience and with the community. So thank you.
No, thank you, Alexandru. And again, I don't think that age is what makes someone sensei, to be honest, because we do have a lot of people who are advanced in age, but not necessarily have learned or what takes to do a great work. So maybe we'll start from the beginning, a little bit about yourself. How did you start doing interventions? How did you go in CTO, PCI? How did your journey go?
Oh, this depends actually on how much time do we got and how far do we go back on my genesis. We will start with the interventional cardiology or with cardiology because maybe it's more interesting. We started when I was a student and I fell in love with cardiology. This happened in my second year actually, so it was really early. I was doing during summer. The students from Romania have to do like a one month or a few weeks practice in the hospital. So I really loved the emergency department. So I went to my hometown, which is a really small city from Transylvania, and I did my practice there in the emergency department. And all I did for a few weeks is to perform the EKG to all patients coming to the emergency department. Not reading the EKGs, just doing it. So, and then I kept seeing all these funny pink paper with lines, and I didn't understand it. It was like a foreign language you could learn. So I got really frustrated. So I went online and I bought myself a book on my second year, and I started to learn EKG by myself, to understand all these lines on that pink paper. So this is how I myself really fell in love with cardiology through the electrocardiogram. As a student, it was fascinating. Like I said, it was an um, alphabet. You could understand a language just by lines going up and down. You can understand actually pretty a lot about your patient. And then I finished medicine, and then I chose cardiology, and I entered through the cardiology residency. And then how I fell in love with interventional, I think it was a combination, and it's always a combination between, some people say luck, I say privilege, and a, a, a bit of passion, and a bit of it's a bit of doing your part, meaning hard work, discipline, having passion on what you do, but it's also a bit of outside interventions that you're not in control of. So this is what actually happened to me. My first 6 months on the cardiology residency, I went just accidentally on a holiday in the summer. So I did 6 months summer in a hospital, and then I had to move to another hospital, and I was not there at the first week of that hospital, and all other colleagues were sent to one specific primary doctor, or one specific specialist, uh, and they forgot about me. So I came 1 week later and I say, "Hi, Alex. I'm also part of the group, and I want to work here, and I have to work here." And it was a normal cardiology ward. It was not a interventional cardiology ward. And the professor, she was an old lady. Actually, uh, that year was her last year as a doctor, as a cardiologist. And she said me, "You know what? We are already settled and organized. Do you want to go downstairs? There's an interventional cardiology department there. I don't get along with them, but if you want, you're a boy, you can go there." And I said immediately yes. And from that point on, I think I was exposed to cath lab on everyday basis, even from the really early. And this is something I really believe in right now, and I encourage, if you want to do this job, you need to be exposed from your really early uh, career.
Wonderful. So some serendipity there, I guess, arriving a little late and being
Yeah,
instrumental of what happened later in your life.
yeah.
But then, how did you get into complex and CTO? Was that something from early on you were interested in that came later on? And why did you decide to pursue this extra work?
Well, that happened a few years later. So I was working on this department all the time, trying to learn interventional cardiology. But it was a basic one. Back then in Romania, we didn't do. I mean, no CTOs. The bifurcation and left mains were done only by a few operators. No imaging, no special wires. So I was exposed to like a basic primary, like I would say primary PCI mostly, acute coronary syndromes. But I got really good at that. But I wanted to do more. And what actually, again, some fortune in your life. I won the EAPCI fellowship grant from the PCR Congress in my third year. So that actually was a huge step and change in my life, actually, because I won that fellowship that meant to travel for 1 year in a different country, in a hospital, and do again only interventional cardiology. And funny enough, I was, because you win the fellowship, and they also choose the hospital where you should go. And I was sent to a small hospital in south of France, and they said yes, and then they stopped answering their emails, and everybody started their fellowship. And again, I was the last one, really late, not to start with the fellowship. And then all of a sudden, I received an email from the president who was dealing those grants back then, Gabor Tot. Probably you know him from the
Yeah.
PCR community. He's from Graz, Austria. So he told me, you know what? Sorry for this mix up. Uh, to make things better for you, I invite you to my center. So I got switched from south of France small hospital to a really big one with Gabor in Graz for 1 year. And actually that year changed my life in terms of complex PCI, because I really learned a lot from him. And in the same hospital is Stefan Harb. You know him. He,
Sure.
he also he also had an interview with you on this podcast. So I also met Stefan, and I started to like CTOs, and I was entering with Stefan, scrubbing in on every CTO, and I was scrubbing in with Gabor on every complex PCI. He was doing all these bifurcation, left mains, impella, and so on. So my fellowship was ending again after having a really nice time. And Stefan was I was really getting along with Stefan, so I really owe him a lot, because he was taking care of me and so on. And he told me, "What do you do after you leave us? Do you want to go home, or you're gonna do something else?" And I told him I don't want to go home yet. And he said, "I have a friend. I will try to call him, and his name is Gregor Leibogut." And again, that's why I tell this story, because it's also a bit of destiny. It's also to do your job, your part, to be involved, and to win your position and your status. But it's also a bit of help from the community. So he called Gregor, and he said, "Actually, I'm really busy right now. I cannot take a fellow. it's a small hospital. We need to think about it. So he didn't give me a definite answer. So I went back to Romania, again a bit unhappy. But then after a few months, I received the email from Gregor saying, "You know what? I have a position. It's not much. I cannot take you like an official one, but it's gonna be like a student research thing. You cannot scrap too much in. But if you wanna come, just come." And I was not so happy, but as I said, okay, but it's better than Romania, and it's Switzerland, and it's Gregor. I've heard so much about Gregor, and I just it's enough even if I go there and I see what he does, and then I went to Gregor, and actually it was a small hospital. It was only Gregor and one colleague doing cath lab, female doctor, and after 1 month, that female doctor got pregnant, and Gregor came to me and said, "You know, we need someone to do the cath lab. It's too short notice to hire someone and to do a like a interview and so on. Do you want to take her place, and I will cover you?" So again, I said yes to something that was not really. I mean, it was not really something promising, but but once you go there and he sees you that you're a good man, and you know cat lab and so on, and you want to learn immediately, things can change for you. And this is what happened to me. I started as a research student, and I ended up like an independent operator, and that was the place where I really learned CTOs with Gregor Leibungon, and I owe him so much.
Wonderful. So you learned some of the best, Stefan
Yeah.
Harp, Gregor Leiberhood, phenomenal operators, and great experience. And what did you find the most difficult thing to learn in CTO? What were the things that you found difficult?
Uh, Difficult for me means getting in a stuck point, in a failure mode at some point. Normally, it's pretty late in a procedure. You have hematoma, you cannot connect the wires, you are uh, with the wire retrograde, wire antegrade, but you cannot connect them. And the patient gets uncomfortable, and he says, "Are we there yet? I'm not. He's not patient anymore." And then for me, that was really hard to uh, understand when to stop, when to continue, and this is what, for me, that's a major, probably psychological, but also technical difficult time in CTO PCI.
Wonderful. And then when it comes to dealing with the complications, when things don't go as planned, how do you take that? Does it affect you a lot? Do you get stressed out? Do you get depressed? How do you react to all that?
To be honest with you, Manos, I still get quite emotionally about any complication, and I think it's normal. And whoever does not have any emotions about it, I don't think he cares enough, at least about the patient. Um, what I believe in, I think most people are going to value you if they see that you're totally driven by the best outcomes of the patient. And that means also, if you're not comfortable doing a case, to say no. It's okay to say no, but at the same time, of course, make sure that the patient will receive the care that they need, and that means refer it to someone else. And that's the time when your senior partner becomes very, very valuable to you. And that's when the community will see that the complex case that you brought, that was brought to you, you did not recognize limitation about that case, but you recognize complexity. And as I said, I get pretty upset when I have a complication, and I take it home with me, and I think about it for a few days. I'm not sure if that's good, but yeah, this is who I am. Also, when I have a complex case, normally my strategy is to stop, and that's good for two reasons. One reason is that from what I've learned from my experience, if I stop and then I look at the angio, sit in quiet 10 times, then you see it you see it differently. And then from an immediately, this patient is for surgery, sometimes you make yourself a plan. And if you ask my fellows, it's really often when I come the next day in the morning and I tell them, stop, don't send this patient to surgery. I have a plan, like an Eureka moment. And I think this comes with stopping on every complex case, and maybe as I said, look at the angio many times, talk with someone about the case, ask an opinion. And the second aspect is, um, if you stop, you can also consent the patient properly. If you don't stop in a complex case, and sometimes this brings back bad karma with you. Every complication usually comes with a case that you wanted to solve it quickly and you didn't speak with anyone else. And it's good also when you have a complex case and it's really difficult, like a cheap case, to tell everyone, the nurses in the cath lab. Usually I make them aware, look, this case is special, so please be focused. And I tell everyone, maybe I call my friend from the ICU or from the anesthesia, look, you don't have to come, but just so you know, I'm doing a complex case. So they are already, aware of me doing a complex case. And all these plannings, I mean, there is no data, but I think they are associated with better outcomes for the patient.
Wonderful. And absolutely, you can never plan enough. And the more time you spend preparing, the better outcomes will be. So this is great. But Alexandru, tell us a little about how you built the program in Romania at your hospital. So you trained, with the best people as we discussed. But then, how did you start the program, build the program, make the people believe in it? How did that go?
Well, our approach in Cluj, in Romania, is, as I told you before, how we prepare the case. This is a bit of, but we always, it's a rule now. Every chip case means two operators. We talked. We are not so many. We are 8 interventional cardiologists, and we talk between us, and we said, whenever there's a complex case, let's go two at the table. And I think this also changed a lot. We 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 have our approach to put everything ready on the table. Maybe have a good line, like a venous line. Maybe put a femoral. Talk with the ICU, and these are all practical things, that ensures a bit of safety. Unfortunately, in Romania, we don't have mechanical support. So what I'm telling you, it's especially important from my perspective, from my place of work, because we don't have any mechanical support apart of the EABP, which is not so great. So we really have to prepare the case and put well the indication and talk with the patient, talk with the family, and also talk in between the team. And yeah, this is what we do. And what else we try now? This is something new that never happened before. We try also to teach youngsters this job, so they are not forced to travel so much and learn it from another country or from somewhere else.
Perfect. And then, how do you choose the people that you train? How do you tell that someone is going to do well in CTO and complex or other cases, and they get inspired to teach them?
Well, here, there's two sides. One telling or defending that everyone can be an interventional cardiologist. You just need the volumes and the numbers, and you just need to practice. And then if you do that, you can do this job. And actually, that's partially true. I'm more defending the second one. That means that you have to have a bit of, how do you say it, gift. You have to be a bit of, you have to have a bit of talent on this job. It's not for everyone. So this is something I believe in. Interventional cardiology is not for everyone. Some people really struggle and they do numbers, but their learning curve is not going as as great as someone who comes maybe uh in because you work with so much youngsters and so on, and some fellow struggles maybe for a year, and then someone else comes and in 3 months he can do it. So I'm a believer of this of the second side, that interventional cardiology needs hard work but also a bit of talent.
Wonderful. And then, Alexandru, that can be a fairly demanding job with a complex risk and everything. What do you do for yourself to keep yourself in good shape and good spirits to be able to do this complex work?
Oh, I used to to do a lot, and I used to have a life. I don't have it anymore, unfortunately, and that's bad. I work a lot. I work from 8 to 8 every day almost, apart from Friday. I used to hike a lot, do a lot of sports. I used to even I love biking, and I used to even build bikes from scratch. Build the wheels and paint them. I was really passionate about that, but unfortunately, I lost that. I don't have time anymore. But I still go every weekend in the mountains. I really love nature, and that also I feel really nice in outside. I don't like cities and traffic and so on and big cities. I always like to go in nature, and also it helps me with the batteries to refill them.
And do you have any favorite book or any favorite movie?
Oh, should I say just one, or am I allowed to say more?
Whatever you prefer.
Because it's really hard to say just one. Movies. I'm gonna say three, if I'm allowed. I really love the TV show. It's not a movie; it's a TV show called Dark. Everyone should look at it. It's the only meaningful and digestible TV show about time travel, and it's really nice. It's a German TV. It's a German TV show. And what else? It's an old movie from Iran. I really like movies, and I don't like all these commercial movies. But what I like, it's an old movie from the 70s from Iran, from an Iranian director called Abbas Kiarostami. It's called Where is the Friend's House. It's really nice. And another one from Germany, Das Leben vom anderen, the life of others. It's called from. It's happening in the World War II. It's really nice. And books, I would I will say two, and those two are going back to my younger age. I really love the Vinnetou Indian book series by Carl May, and another book I really got impressed on. It's called Nobody's Boy. I think Sans Famille in French by Hector Malot.
Wonderful. And why do you like those books? Is it the adventurous side? Is it the
Exactly.
quest?
Yeah. All about quest, because I love, for example, Lord of the Rings, Harry Potter, or and the books from Jules Verne. I was really loving all these quests and ventures, going to different worlds and having a hero and so on.
Wonderful. And then, how many hours do you sleep? You just say you work many hours a day. How many hours do you go to sleep?
I still sleep enough, I think, because when I come home, I just fall in my bed. I'm going to my bed before 12, before midnight, which is good. So I sleep 6 hours.
Okay. Okay.
Mm.
Wonderful. And then, what are the things that excite you right now? What are you most excited about in intervention, CTO, or in general?
Intervention, which really excites me a lot. I think we are doing one of the, if not the most interesting job in the world, for real. I'm not, maybe I'm biased, of course, but to go inside the body in an alert patient and do whatever, and these things is really expanding right now. So I'm really happy I chose this, because excites me how interventional expands on every year. You can put files now everywhere. You can go everywhere and treat more and more disease from inside. And now there's even TAVI with local anesthesia. So that's amazing. And they go home maybe even the same day. So we will do soon ambulatory TAVI, which is great. I think we are doing a really interesting job.
Wonderful. And what are you most proud of? Again, you've done a lot of work, built a great program. What are you most proud of, personally and professionally?
Proud of my job, and also because it was not easy traveling so much. I was traveling in 3 different countries in the past 4 years, and I was traveling in the COVID era, which was really difficult, trying to fight with the frontier policemen and trying to get in the country, and so on. And I always had my pillow in my back of my car, and transporting all my things back and forth Europe for some quite of time. So that was not easy, and I'm proud that it was I was I wanted to do that, and um, that paid off right now, and I'm really happy in the hospital where I'm working now, and I'm also in the university, and I'm teaching to students, and that's something else I'm really proud of. I have students every day. They follow me everywhere, and I show them all these interesting things, and I try to make cardiology and interventional cardiology especially really interesting. They are really excited, and they keep telling me nobody showed them the cardiology with so much passion, and giving them attention and time and so on. And on the personal side, I'm proud of meeting my wife, Bogdana. She supported me so much, and she endured me, and she tolerated me probably so much because I was away so much, and she always pushed me and understood me about, because this is something in your head. And she didn't stop me, but she was also pushed me even more. So I'm really grateful to be with her.
Wonderful. So, Alexandru, if you had to give some pieces of advice for the new generation, the people coming afterwards, fellows, interventional and otherwise, what would you recommend to them? What would you suggest for them to do?
Well, I'm a living example that uh, like the theory of prioritize later, to sacrifice something now in order to obtain some good later. And I'm a living example of that. uh, to be able to sacrifice something now and do that because it's going to pay off later. And there is no better time than when you're really young and you don't have kids and you don't have family yet, and you're still like a sponge and you absorb everything. So really, it's not even sacrifice. It's like be able to be willing to travel. And there's also, two sides on this. How do you learn CTO, PCI, and CHIP? Is it by proctoring, or is it by fellowship? Well, I strongly advocate with fellowship.
Wonderful. Yeah, I mean, it's the more structured way. You get much more exposure, more time. Of course, that means taking some time off and working on it, which can be sometimes difficult. But this is great advice. So, Alexandru, thank you so much. Really appreciate you taking the time to speak with us today. Congrats again on building an excellent program in Cluj, and
Thank you, Manos.
looking forward to seeing you at the live case and some meetings.
Thank you, Manos, so much for the invitation. See you.
Thank you for listening to the Sensei podcast.